Okay, well, welcome everybody, and thank you for joining us tonight for obviously a special series for our group of endocrinologists entitled Realize, React, and Reflect, which is a spin-off of course, a patient profile assessment, which a few of you might be familiar with as we've done a few programs like this in the past. We obviously have a unique opportunity here to both learn about new indications for medicine, new medicines, new mechanism of action, but also the applicability of patient to this clinical data. And of course, your own insight is valued by everybody here, as well as our sponsor, which we'll come to momentarily. Tonight's program is entitled Faith in Fidelity, a New Pillar in Diabetic Kidney Disease. Most of you know me. I'm Alex Abitbol, and I'm obviously happy to be here as well, both as a steering committee member and participant in the program. These are my disclosures. I've obviously had the pleasure of working for most of the companies that have anything to do with diabetes or metabolic disease. And of course, tonight's program is sponsored by Bayer through an unrestricted grant. They don't have anything to do with the content or any of the material or surveys. That's all put together by the steering committee. And the presentation will contain things regarding indications, which of course might differ from the product monograph available in Canada, which is why we're presenting both clinical data and seeking your opinion. Statements do not reflect, of course, anything that relates to Bayer or LMC Healthcare. So a patient profile assessment, since we do have some new people probably joining for their first LMC PPA, involves a few different components. First, we review some of the program materials and build a patient profile, which I'll come back to at the end of the program to give you more information about. We'll gather insight from all of you, both at the conclusion of the program and later in an evaluation, which Nikki or I will share. And then for the bulk of the program, we're essentially reflecting on what we learn here today in our real life clinical practice, and there'll be some feedback that we seek from you at the end. Learning objectives, we'll discuss the morbidity and mortality in people with diabetes and chronic kidney disease, exploring, of course, the role of non-steroidal MRAs, in particular finerenone, as it's recently become available in Canada and indicated for people with type 2 diabetes and CKD. And of course, the whole purpose of us being here as a group is to determine the patient characteristics of who's most likely to benefit from this kind of treatment. And so, like I often get to do, far too often, and it's my pleasure to do so, I get the unique opportunity to introduce Dr. Ron Goldenberg. Now, I know what some of you are thinking. We were all at a special dinner for Ron's retirement, and he's here anyways, presenting, of course, to us because he likes us and because we really couldn't do these programs without him. Plus, everybody else on the line realizes that he's not really retired, but he's he was a consultant endocrinologist at LMC Healthcare for over 20 years. He was also a consultant endocrinologist at North York General Hospital, participating in hundreds of clinical trials, serving on numerous guideline committees, and of course, everybody's favorite expert when it comes to, well, pretty much anything. And so without further ado, I'll introduce Dr. Ron Goldenberg. Thanks again for presenting.
Well, thanks, Alex, for the kind introduction, and it's nice to see you all virtually. Maybe next time we can get together live. Certainly more live meetings are coming on board these days. And thanks to you, Alex, and Nav Tangri, who I know you'll introduce a little later, for helping us put this program together. Good things are worth waiting for, and I've been speaking on finerenone for like 3 years already, but finally it's arrived a few months ago in Canada, and you can prescribe it in the clinic. And I think the purpose of tonight is to, first of all, update everybody about finerenone and where it fits, and then more importantly, to describe this practice assessment program, which we've done in the past and has been successful to kind of spark us about thinking about a new agent and how it fits into our practices. So let's start and talk about type 2 diabetes and chronic kidney disease. I'll start off and talk a little bit about residual risk, which is a segue into why we need newer agents to reduce the burden that our patients with type 2 diabetes and CKD often develop. So these are my disclosures. And so we all see patients with CKD every day in the clinic. Around the world, about 1 in 10 adults have some degree of CKD. And for endocrinologists, we should know that about 40% of our patients have type 2 diabetes, and about 20% of patients with CKD also have heart failure. And so when I show you the data looking at renal outcomes, it's also important to look at cardiovascular outcomes with an intervention, including the outcome of hospitalization for heart failure. Many of our patients die from CKD, largely because they progress to end-stage kidney disease, and diabetes kidney disease is still the leading cause of end-stage kidney disease. So we're all quite comfortable about initiating a RAS blockade and more recently SGLT2 inhibitors in our patients with CKD and type 2 diabetes, but I'll show you 2 slides to highlight the residual risk. So data from Credence is on the left and DAPA CKD on the right. In each of these trials, individuals were already on a background of ACE or ARB, and then they were randomized to get SGLT2 or placebo. And you can see both on the left and the right of the slide, there's about an 11 to 12% of patients still having significant renal outcomes, despite adding an SGLT2 inhibitor on top of ACE or ARB. And so this shows us that, and we see this in the clinic, right? We have patients on their ACE or ARB, we have patients on their SGLT2, and we still see their GFR dropping over time. And similarly, there's a big burden of CV death or heart failure. And so this is the data from the same studies, but looking at the outcome rather than progressive kidney disease, looking at CV death or heart failure. And again, you still see a significant residual risk even in the SGLT2 inhibitor treated patients. So an opportunity to intervene beyond ACE or ARB plus SGLT2 inhibitor, maybe in some cases, initiating a newer agent on top of ACE or ARB for patients that maybe aren't candidates for an SGLT2 or maybe have had an intolerance to an SGLT2. So that brings up finerenone, the newest kid on the block, or what I would say the newest pillar for managing CKD in patients with type 2 diabetes. And so we've known for a long time that the drivers of CKD progression in type 2 diabetes include hemodynamic factors, metabolic factors, and we also have learned that inflammation and fibrosis is an important component of progression of chronic kidney disease. And it's via these 3 drivers that you get pathological damage to the kidney, ultimately progresses to fibrosis, which leads to CKD progression. Initially, you may see albuminuria, then you see decline in GFR, eventually end-stage kidney disease. So this slide just reminds us that we've been able to treat the hemodynamic component of CKD progression with ACE or ARBs and SGLT2 inhibitors and perhaps other antihypertensives. We've been able to treat the glucose or the metabolic parameters with antihyperglycemic agents, but we've never had agents that specifically target inflammation and fibrosis in the kidney. But we know from preclinical data with finerenone, which we'll describe in great detail, that it does have anti-inflammatory and anti-fibrotic effects. And although it is a non-steroidal MRA or mineralocorticoid receptor antagonist, it doesn't seem to have the blood pressure lowering effects of the MRAs we're used to. It has a modest blood pressure lowering. So a lot of the benefits are probably more directly targeting inflammation and fibrosis independent of a drop in blood pressure. So you're probably familiar, and at least to some degree, the columns in blue of the older aldosterone antagonists, spironolactone and eplerenone, and on the far right, we'll just briefly compare finerenone. So it's important to know that it has a different molecular structure. It has very high potency and selectivity to the mineralocorticoid receptor. It does not penetrate the CNS, so you don't have to worry about any neurological effects. And it doesn't have the sexual side effects that we're all used to seeing with spironolactone. So it has no anti-androgen products like effects like spironolactone. You'll see hyperkalemia in the clinical data, but there in early trials, head-to-head finerenone versus spironolactone, significantly less hyperkalemia. It has a very short half-life, or 2 to 3 hours, and there are no active metabolites, which is quite different than spironolactone. And that could be one of the reasons with spironolactone we sometimes run into problems with lingering hyperkalemia, which is sometimes due to the metabolites rather than the actual drug. So I'm going to briefly show you the key features of the 2 major phase 3 trials with finerenone. First one shown here, Fidelio DKD. The second one is Figaro, by the way, both named after operas by Beethoven. And then I'll show you a pooled analysis called Fidelity, and hence the title of tonight's event. So Fidelio DKD ended up randomizing a little less than 6,000 patients to finerenone or placebo. And the kind of patients that they enrolled in this trial were pretty high-risk kidney patients. So if you see the KDIGO heat map in the middle and bottom of the slide, you can see if patients had A2 category albuminuria or a moderate elevation in albuminuria, they had to have a GFR in the 25 to 59 range. And those with severe albuminuria or a ACR ratio greater than 33.9 had GFR levels anywhere from 25 to 75. So they were looking for people on the heat map who are at a high to very high risk of kidney progression. And you can see the percent of patients that they enrolled filled into this heat map. And so the large bulk of them had severe albuminuria, and most of them had GFRs below 60, so that the median ACR was 96 milligrams per millimole, and it was in the macroalbuminuria range in almost 90% of patients, and the mean GFR was 44. So probably a lot of these patients see nephrologists like NAV rather than us. So it may not be the kind of typical patient that we manage. So this is the primary outcome. It's a composite renal outcome of kidney failure, GFR decline of 40% or more, or renal death. You can see a statistically significant 18% relative risk reduction, and the curves start to diverge after about 1 year of follow-up. There was an exploratory kidney outcome using a 57% decrease in GFR rather than the 40%. You may ask why they did this. Well, 57% drop in GFR is roughly a doubling of creatinine, and that's been a kind of a traditional outcome in many kidney trials going back many years. So if you substitute 40% to 57% decrease in GFR to the composite outcome, there's still a significant risk reduction, but it's even more dramatic at a 24% relative risk reduction. And then this is just the forest plot of all the components of that primary composite outcome, understanding that the trial's powered for the composite, but all the individual outcomes are to the left of unity, even though other than the 40% drop in GFR, the individual other components aren't statistically significant, but probably it's just underpowering. And I'm going to show you the same data when we look at the fidelity pooled analysis, where you get more power, and then you show each of those outcomes being statistically significant. Renal death's hard to comment on. There's only 4 outcomes, 2 in each group, so definitely underpowered for that outcome. This was kind of unexpected, but they plotted the GFR over time in both the finerenone group and the placebo group. And this is kind of what we see with SGLT2s. You see that initial drop in GFR, and then it kind of, the slope flattens out. The placebo continues to drop. And at about 24 months, you can see that the drop in the placebo starts to be more vigorous than the drop with finerenone. So if you look at the chronic change in GFR after the first 4 months, finerenone patients drop by 2.7 mLs per minute per year, and placebo almost 4 mLs per minute. So over time, finerenone preserves GFR compared to placebo. Well, is it safe? Yes, it had a modest drop in blood pressure of only about 3 millimeters per mercury. Didn't affect A1C or BMI, so a little bit different than SGLT2 inhibitors there. No difference in acute kidney injury and no sexual side effects. So definitely you don't have to worry about this like we're used to with spironolactone. But of course, it's an MRA, so you might expect some hyperkalemia. So they found 18% on finerenone and 9% on placebo. So that's about a doubling, but very unusual to permanently discontinue the drug because of hyperkalemia. So you have the patients who get hyperkalemia, sometimes the drug is down titrated, or sometimes it's held for a bit and then they resume it. And we'll hear a little bit more of the practical issues of hyperkalemia from Nav a little bit later on. I like this slide because it puts Fidelio DKD and the absolute benefit on the far left in the context of the SGLT2 inhibitor trials, which you all know. This is number needed to treat over the duration of each of the trials, and they're all in the same ballpark. Just a word of caution, the duration of each of these trials is a little bit different, and the outcomes are a little bit different. But the top line summary of this is that the absolute benefit of adding finerenone to patients with diabetic kidney disease seems to be similar to what you see with SGLT2 inhibitors as far as absolute risk reduction is concerned. So the next one is Figaro, and Figaro I think is a little bit more relevant to an endocrinology practice because they're patients who were more at mild to moderate risk of progression rather than the more severe Fidelio patients. So this is almost 7,500 patients randomized to finerenone or placebo, and the primary outcome was a composite outcome of cardiovascular events. So they kind of flip-flop. The primary outcome in Fidelio was a renal outcome. Here it's a cardiovascular, but of course they looked at secondary composite kidney outcomes as well. And you can see that these are kind of milder patients. So if you had albumin creatinine ratio 3.4 to 33.9 milligrams per millimole, you can have a GFR 25 up to 90. And if you had severe albuminuria, your GFR was in the 60 to over 90 range. So patients generally have better GFRs than in the Fidelio study that we just showed you, such that the mean GFR here was 68 and the median ACR was 34. So just at the very beginning of the A3 category on the heat map. Over 60% had GFRs over 60 and almost half had ACR in, I guess, what we would call the microalbuminuria category. So this is the primary cardiovascular outcome: CV death, MI, stroke, heart failure. It's a 13% relative risk reduction. Again, the curves start to diverge at maybe just before 1 year. And in this composite outcome, the main driver was a reduction of 29% in hospitalization for heart failure. So finerenone seems to have a great benefit on kidney outcomes and a significant benefit in reducing hospitalization for heart failure, even though significant HFrEF was excluded to get into this trial because it's unethical not to offer them an MRA based on earlier data. But probably these patients, some of them had HFpEF, I guess, and they may have been at risk in the future of not just HFrEF, but HFpEF as well. So the two secondary renal outcomes they looked at are on this slide. On the left, using a 40% drop in GFR. On the right, a 57% drop in GFR. The outcome on the left didn't quite reach statistical significance, but using that more robust 57% decline in GFR in the outcome, or roughly a doubling of creatinine, you see a significant 23% relative risk reduction. And it's interesting, within the composite outcome, the component of end-stage kidney disease, although it was pretty low in both groups, it was statistically significantly reduced with finerenone versus placebo. So you were less likely to end up on dialysis with finerenone versus placebo in a group of patients who weren't extremely high risk to end up on dialysis. Otherwise, no surprises. Again, no sexual side effects. Hypertension was less likely in finerenone, but hypotension, because it drops blood pressure a little more likely, but it's 4.2 versus 2.5%. Overall reduction in blood pressure, a little less than 3 millimeters of mercury, and no effect on A1C. So the really only difference between Fidelio, the first trial that I showed you, and Figaro are the inclusion criteria based on ACR and GFR. Otherwise, the trials were designed to be carried out in a very similar fashion. So there's actually great fidelity between the two trials, and hence this pre-specified pooled analysis called Fidelity. And so here you have a much broader spectrum of patients when you look at the KDIGO heat map, because you can have patients with microalbuminuria with GFRs between 25 and 90, and you can have patients with macroalbuminuria with GFR levels ranging from 25 to over 90. And so they pooled these 13,000 patients and looked at the key outcomes of the composite cardiovascular outcome and a key renal outcome using the 57% drop in GFR. And this was all pre-specified when they initially planned these two trials. So a good spectrum of patients, but a lot of pretty mild patients. So 40% of the patients had eGFRs over 60, and about a third of them had A2 albuminuria, or what we often call microalbuminuria. So the median ACR was 58, and they had a significant number that were also microalbuminuria. So this is the cardiovascular outcome. You can see this 14% relative risk reduction. And these are the components. And I just want to highlight the hospitalization for heart failure, even though CV death and non-fatal RMI are to the left or on the right, on the side you'd like to see. It's the hospitalization for heart failure that's the most dramatic benefit in the composite CV outcome. No overall effect on all-cause mortality, barely not significant. The hazard ratio 0.89 with the upper limit of the confidence interval 1.001. If that was just less than 1, it would have been significant. Sudden cardiac death was significant, 25% risk reduction. And if you do an on-treatment analysis rather than an intention to treat analysis, all-cause mortality becomes significantly reduced by an 18% reduction, and CV mortality becomes significantly reduced also with an 18% risk reduction. So data from Fidelity shows the hard renal outcome benefit, composite cardiovascular benefit, especially heart failure, but also if you look at on-treatment benefits on mortality. It didn't matter what your GFR was or what your ACR was. There was no interaction. So the benefit is consistent, in this case, of the cardiovascular benefits across the spectrum of GFRs and ACR levels. And as far as the kidney outcome is concerned, again, using that 57% drop in GFR as part of the composite, a 23% relative risk reduction. And because you had more power than the individual trials I showed you earlier, each component of the composite renal outcome is statistically reduced with finerenone, except renal death, where the numbers are way too small to make any conclusion. But a reduction in kidney failure, end-stage kidney disease, GFR less than 15, or a 57% drop in GFR. So the kidney outcome, similar to the cardiovascular outcome, it didn't matter what your GFR was or what your ACR was. There's this statistically significant or suggestion of a benefit with no concerning p-value for interaction or heterogeneity. Now, there weren't a lot of patients who were on an SGLT2 inhibitor in the FIDELITY program, only less than 7%. And the reason for that is these trials were ongoing before we started using SGLT2 inhibitors in kidney patients. Remember, when SGLT2 inhibitors first got launched, they were actually contraindicated in patients with GFR less than 60. And it was only later that the benefits in kidney patients emerged that we started using them in kidney patients. So there were only 7% of patients on an SGLT2 inhibitor because it was unusual while these trials were ongoing to put these people on an SGLT2 inhibitor. Despite that, if you were already on an SGLT2 plus your background ACE or ARB, there was still this nice reduction in albuminuria when you added in finerenone, which is interesting because we already know the ACE or ARB would have dropped albuminuria. The SGLT2 would have further dropped albuminuria. Now you get even a further drop if you were on a baseline SGLT2. But the most interesting thing about the SGLT2 group is that if you were on an SGLT2 inhibitor, you really had the same benefit if you weren't, because the p-value for interaction is nowhere near significant. So whether or not you're on an SGLT2, finerenone benefits the CV outcome, the kidney outcome, hospitalization for heart failure, and there's even the same suggestion or effect on all-cause mortality. Overall reduction of 3.7 millimeters in mercury, no sexual side effects, and yes, about a doubling of hyperkalemia, but very unusual for that to lead to permanent discontinuation of the drug. Now, some of you may know that in the SGLT2 inhibitor trials like Credence and even meta-analyses of SGLT2 inhibitor trials, SGLT2 seem to reduce the chance of hyperkalemia. So if you look at the right side of this slide, SGLT2 inhibitor patients who ended up on finerenone had 10.3% hyperkalemia, but that was 14.3% if you were on finerenone without an SGLT2 inhibitor. So in some sense, having the SGLT2 inhibitor on board may lessen the likelihood of hyperkalemia with finerenone. I'm going to skip that. So what did the guidelines say? So the most recent international guidelines come from KDIGO. They were updated in 2022. So this is for diabetic kidney disease. And what you see here are the foundational therapies for diabetic kidney disease. So at the very bottom, diet, exercise, smoking cessation, weight loss. The next tier are first-line drug therapy, are metformin. It's still hard to get rid of metformin, but it's metformin with an SGLT2 inhibitor, of course, RAS blockers, and of course, statins for these high cardiovascular risk patients. But then there's additional drugs with heart and kidney protection, so additional pillars of therapy. And I just want to highlight that this is where finerenone comes in. So KDIGO is having this as an important therapy for our patients with diabetic kidney disease who may already be treated with an SGLT2 inhibitor and a RAS blocker. And this is the entire KDIGO algorithm shown in a little bit different fashion than the pyramid on the previous slide, and just highlight that you would give additional risk-based therapy, and in this case, a non-steroidal MRA, in any patient with an ACR greater than 3 milligrams per millimole and a normal potassium, so probably less than 5 millimoles per liter. And this would be usually on top of RAS blocker and often on top of an SGLT2 inhibitor, which is a first-line drug in this algorithm. And so that's how KDIGO has integrated the finerenone data into a management algorithm for these patients. So I'm going to stop there and I'll hand it back to Alex for a second to introduce NAV, and then we'll all stick around to have a discussion at the end.
Thanks, Ron. What a great presentation. And thank you to everybody who's obviously been filling the straw poll in the chat, as we obviously wanted to get some bearings when it comes to our own experience with finerenone. And as many of you can obviously see, We don't have a lot of experience with finerenone, so we're very fortunate to have Dr. Navdeep Tangri, who is a physician and professor in the Division of Nephrology at the University of Manitoba. Dr. Tangri's research program is clinical and translational and focused on improving clinical decision-making for patients with chronic kidney disease. He developed and validated the kidney failure risk equation, which we'll hear about shortly, as the gold standard to predict the need for dialysis in patients with CKD. He also leads national and international multi-center randomized clinical trials in the CKD population. And obviously, we thank you so much for participating in the steering committee and, of course, for presenting tonight your own expertise with both kidney risk and with finerenone. So I'll pass it to you, Dr. Tangri.
Thank you, Alex, and thank you, Ron, and thank you to the LMC team for allowing me to talk. So I've actually had an interesting bit of experience with finerenone. So I started working on a series of research projects with Bayer about a year ago, particularly some post-approval work in the US, where finerenone's been around for a year, and a lot of knowledge translation efforts related to my work in risk prediction, which I'll talk to you about. And then in Canada as well, we're doing studies trying to highlight this residual risk concept. But residual risk is, one part of residual risk is this idea that that a group of patients with kidney disease are at high residual risk. So the entire group of patients with diabetic kidney disease have high cardiorenal risk. My work tries to dig a little bit deeper than that and says, well, what is the risk for the individual patient in front of you? And as you start to use the therapy, how do you identify the patients at highest risk and therefore those who have the greatest benefit? So with that, I think I have control. Perfect. These are my disclosures. So my vision is that CKD is very common. 1 in 10 Canadian adults have CKD. Probably 1 in 4, 1 in 5 with diabetes has chronic kidney disease. But not all chronic kidney disease is the same. I think you'll agree with me that a lot of patients with chronic kidney disease do not progress. But we do need to identify who's going to develop CKD progression. And then if we can, I think we can potentially now treat them with sort of a pillar-based therapy approach, RAS inhibitor, SGLT2 inhibitor, and non-steroidal MRA to prevent CKD from ever progressing to later stages. So really what we're talking about now is preventing the lifetime risk of dialysis. And that's why I'm here speaking with you instead of speaking with my peers per se, because when I talk about my peers, the nephrology community in Canada, we're seeing patients at an average GFR of in the 30s. At that time, even if you initiate optimal therapy, you're likely to delay dialysis rather than prevent it. Whereas often when these patients are in your practice and in primary care and in cardiology, if they're identified early, the fast progressors, you can actually prevent dialysis. So just keep that in the back of your mind as we go through the slides. So again, just setting the stage a little bit. So the prevalence of early stage kidney disease is much, much higher than later stage, right? So this is a US slide showing 14.5% of Americans have chronic kidney disease stage 1 to 5. 14 out of 14.5 is 1, 2, and 3. And what about awareness? Completely the opposite. Awareness of chronic kidney disease. So do patients know that they have a problem with their kidneys? Less than 10% at stage 1, 2, and 3, only becoming an issue at stage 4 to 5. So the curves are completely flipped, and everything sort of starts to happen in this transition from stage G3 to G4. And until then, by that time, the window has really been lost or is almost gone. So that again is summarized really well here. These stages are asymptomatic. So the only way you know this person has kidney disease is if you actually follow their GFR and follow albuminuria. So if you just follow eGFR alone, you'll miss stage 1 and stage 2 CKD. And that's why you need albuminuria. I mean, you look after a lot of patients with diabetic kidney disease, so I'm sure your albuminuria rates are exceedingly high. But across the country, it's about 50% for people with diabetes, and it's about 10% for people without diabetes. So we're really still very much missing the mark in albuminuria. And again, sort of coming to that point that if you let chronic kidney disease progress late, you can only delay dialysis. You cannot prevent it. So here's a slide on why CKD care is suboptimal in Canada. So this is not data from Alberta, 96,000 people with eGFR 15 to 59, 64% did this study. This is academic family medicine practice. I had albuminuria testing, 17% in diabetes. I've looked at national data, it's 50 and 10, okay? With albuminuria taking a RAS inhibitor, 82% with diabetes, 62% without diabetes. Now we know that RAS inhibitors are easy, cheap, generic drugs. Taking a statin, 65-39. Taking an SGLT2 inhibitor, it's probably, unfortunately, it's probably closer to 20%. And that's, again, you might think that that's not practice today, but actually for a long time, as you know, people were afraid of prescribing SGLT2 inhibitors to people with chronic kidney disease. So patients with diabetes and chronic kidney disease, 20% of them, probably if you take a population-based sample, are actually even on SGLT2 inhibitors. So just going back to some of my work and setting the stage for prediction. So in 2011 and subsequently in 2016, we published a couple of papers in JAMA developing risk equations for progression of chronic kidney disease to dialysis or kidney failure. I'm hoping at least one or two of you in the audience may have used our equations. It's called the kidney failure risk equation based on age, sex, GFR, and ACR. We've validated these in 30 countries, more than 1 million individuals. They're highly accurate. They're part of national, international clinical practice guidelines and used by, actually this slide is old, so they're used by almost 100,000 physicians worldwide. If you go to the site that I built, kidneyfailurerisk.com, you can actually enter in a patient's age, sex, GFR, and ACR and determine their 5-year risk of dialysis. And you can go through with a patient that their risk with good blood pressure control can go from 26.8 to 21.2. With a RAS inhibitor, go from 26.8 to 18.8. With an SGLT2 inhibitor, 26.8 to 14.7. And there's going to be a section here on finerenone for people with diabetes. And just this is all done from meta-analyses, highly accurate meta-analyses of randomized trial data only. So really, we've tried to build videos, decision aids, and everything for so that physicians can convey risk to patients, because knowing your risk is powerful. And the next few slides are really going to go into how to find the patients at risk. So just another shout out to my colleagues. So this is a nice study from the University of California, San Diego, which looked at, can nephrologists predict the risk of dialysis as accurately as the equation? So these were the actual treating nephrologists for these 257 patients. And they were asked to determine the risk of dialysis, the patients also. And this is the real outcomes at the bottom. And this is the equation. So the real outcome 1%, equation 1%, doctor 8%. Second group, real outcome 1%, equation 3%, doctors 16%. Third group, real outcome 9%, risk equation 9%, physicians 37%. The moral of the story is, do not listen to your physician's prediction of your risk of dialysis. Tell them to use a validated equation. And this has been shown in other places. We just don't have the numeracy in our head to get to an accurate risk prediction, even if we know the patient. We can figure out who's like 90 to 100% likely to progress and who's 0 to 5% likely to progress. Anywhere in between, totally gray. Okay, so now let's go through another reason why risk prediction equations are needed. So this is dialysis risk on this panel, where it says 2-year risk of KFRE, and this is risk of eGFR 40% decline. What this slide shows is there's a 40-fold variation between patients in the same KDIGO box for dialysis risk, and there's overlap in all the risk categories, okay? So 2 patients who are G3BA2. So a patient right below here could have a GFR of 44 and 3 milligrams of albuminuria. And this patient could have a GFR of 31 and 280 milligrams of albuminuria, sorry, 28 milligrams of albuminuria. And there's an 40 to 80-fold variation in risk. So even though the heat map is better than just knowing someone's GFR, there's so much variability within a single box of the heat map. So, my approach has always been, let's get down to the precise risk for an individual, because then you can actually quantify the precise benefit. All these drugs we're talking about, RAS inhibitors, SGLT2 inhibitors, finerenone, they don't have any risk treatment interactions. What that means is that if the drug is got a hazard ratio of 0.8, if your baseline risk is 1%, your risk after drug is 0.8. But if your baseline risk is 40%, your risk after drug is 32. So one patient may have an 8% absolute risk reduction, and the next patient may have a 0.2% absolute risk reduction. So I've really tried to quantify that, and that obviously has economic considerations as well, but just wanting to make that point one more time. So the KFRE is very good for stage 3 to 5, but I mentioned earlier on that patients, doctors, we all need to strive to find high-risk patients early. So we wanted to develop new models to do this. So we took a data set of patients with CKD stage 1 through 5 and tried to make new models, this time to predict 40% decline in GFR or kidney failure. And that's the FDA approved endpoint. That's why it's used in trial, 40% decline. Because if you have 40% decline, you then have a 20-fold higher risk of dialysis in the next 5 years. And similar to our previous work, we always built models with lab data only, no biomarkers, just data from CBC, chemistry panel, and urinalysis. So why did we do this and how did we do this? Again, another study. First, we looked at SIPSN data, 7,000 patients in primary care practices, and showed that high-risk patients receive indistinguishable care to low-risk patients. 37% statin use in low risk, 40% in high risk, 52% RAS inhibitor use in low risk, 47% in high risk, no difference. Physicians do not see risk. And it matters because here's my patient who's 50 years old in your practice and has the GFR of 80 today. High risk patient is declining at 5 mils per minute per year. I could tell you by our model, whoever we label as high risk, their average rate of decline is 5 mils per minute per year. You get this patient on a RAS inhibitor, SGLT2 inhibitor, and finerenone, they're now at 2 mils per minute per year. And instead of being on dialysis at 64 on just RAS inhibitor alone, 64 would be just RAS inhibitor alone, 85 is with the triple therapy. So 21 extra dialysis free years. Now let's look at a low risk patient. So again, 50-year-old patient with diabetes, GFR of 80, declining at 1 mil per minute per year. That's what our model predicts. If the patient is low risk, their typical rate of decline is 1 mil per minute per year. Put them in all 3 drugs, 0.8 mils per minute per year. No difference to their trajectory at all. So again, just making the point again that if these 2 patients, if you don't look at albuminuria, you don't look at risk, at the GFR of 80 and an age of 50, they may look indistinguishable, and you should not treat these 2 people the same. So we started with 1.2 million individuals in the Manitoba Population Health Repository, where every claim, drug, lab test is captured. We built our models on 77,000 patients with an eGFR greater than 10 who had urine ACR data available. We then validated in 100,000 patients in Alberta, and we used a technique called random forest survival analysis. Our machine models are highly accurate and outperformed a commercial model available in the US. Our accuracy was 87% for a C statistic, which is astoundingly high. We built them on 4,000 events and used only routinely collected data, no biomarkers. We then validated these models in 14,000 patients from Canvas and Credence, 13,000 patients from Fidelity, and in actually, it says greater than 1.5 million, but actually 4 million US adults. And we're implementing them in a large US health system at the moment. And we're actually implementing them in nephrology practices, and I'll share some data from that. So these are highly validated, highly accurate models that find patients early for intervention. Show you some results from Canvas and Credence studies you're very familiar with. First, we achieved an AUC of greater than 0.8. And now here's the part about the high and low risk. 15-fold separation in risk between high and low risk patients in the same trial. What about the benefit from CANA? High risk patients had a 3.5 mil per minute per year benefit from CANA in chronic slope, and low risk patients had a 0.4 mil per minute per year benefit from CANA. So really, again, this very wide separation can be achieved by using a model. Okay, so now bringing it all back to the very first part of the talk. So if you wait till nephrology, it's too late. Nephrologists are seeing patients at 35 to 40. SGLT2 inhibitors, you don't start typically below 20. Non-steroidal MRAs, you shouldn't start below 25. And so you're just delaying. This window is extremely narrow. Okay. Now, what about triple therapy? Is triple therapy safe? I would say yes. When you look at FIDELITY, there's 1,000 patients on RAS inhibitor, SGLT2 inhibitor, and finerenone. And in the people who are on two drugs versus finerenone alone, there appears to be a sense of synergy. The hazard ratio drops from 0.87 to 0.67 for the cardiovascular outcome and 0.80 to 0.42 for the kidney outcome. And furthermore, there's actually less hyperkalemia when you use both agents. So in the US practice, what we've done, and I'll show you some dashboards from the practice, is we've provided a dashboard for the physicians and given them a clinical pathway. And what we're saying is that for patients who start with the highest risk patient and work your way down to intermediate risk and get patients on triple therapy and get them on the highest doses, particularly the patients at high risk. Here's a set of dashboards we built with Roche for use in Europe. Again, they reflect risk front and center. So risk is right in the middle and alerting doctors what to do. We also created reports for the patients that summarize their risk, and we created a report for the doctor. So this is a high risk patient, 60% risk, showing them 60 out of 100. You should always show risk out of 100, never out of 10 or 5. Some people like color, other people like numbers, other people like stick figures. So when you design a report, you should always show all three things. And here we've shown 60% high risk. And then in our report, we've created all the KDIGO guidance from the kidney disease chronic practice guidelines and matched it to the labs and the risk score. So how frequently should this patient GFR be monitored and ACR? What's the blood pressure target? Is referral needed? Are there complications? Anemia, acidosis, hyperkalemia, CKD, mineral bone disorder? And would this patient benefit from RAS inhibitor therapy, SGLT2 inhibitor therapy, non-steroidal MRA, or all of the above? And I would challenge you to say that high-risk patients need benefit from all of the above. Here's our dashboard in our Texas practice, where we are working with actually a Canadian company called Cure Health. And you can see that this is a high-risk patient, fake name, of course, and it shows you what the patient is on. So this patient is on candesartan, Invokana, and finerenone. This next patient is also high risk, but only on candesartan, and these are blank, so the physician can action this in their EMR and improve goal-directed medical therapy. So, my summary of this part of the talk before I launch into the finerenone specifics and talk about my sort of real boots on the ground clinical experience is that accurate risk prediction tools help us make better decisions. We are just not numeric enough to get down to an individual number for a patient, and knowing the number helps. Patients want to know the number. It'll help you make better decisions. What drives the numbers we create? It's GFR and albuminuria. Yes, we use the entire entire sort of inventory of available labs, but albuminuria is essential. And if you don't have access to a risk prediction tool, use albuminuria. The higher the albuminuria, the higher the risk. Our models are sort of entirely lab-based, easily can be integrated into any EMR, but really all models only work when they're part of the workflow. And that was my kind of number one reason to be excited about working on this presentation and with this group, is because I understand that there's an ability here to integrate screening and identify patients in the workflow. And that's the only way models work. So let's switch tracks. Just some very practical considerations for finerenone. I have a handful of patients on finerenone and just how I'm starting it and how I'm approaching it. So I think of it as an adjunct to standard of care therapy. I'm starting with all my patients with diabetic kidney disease who I think have residual risk, and I'm using albuminuria or our prediction equations to identify that risk, and who I think are otherwise optimized. So this is just some contraindications. So obviously patients with Addison's disease, strong CYP3A4 inhibitors, which usually does not happen. I've not found anybody allergic to finerenone yet. This is kind of, the big piece. So if the potassium is less than 5 and eGFR is greater than 25, you can start. Now, most of my patients are starting at 10. In fact, I have no one starting at 20 yet because the handful of patients I have are all with an eGFR less than 60, but you could start at 20 if your GFR was normal, and you could get to 20 if you start at 10. Just like we started in the early days with RAS inhibitors, I always measure potassium and GFR 4 weeks out. Excuse me. I think this might change over time as you get more comfortable with the drug, but I think for now it's absolutely prudent to measure 4 weeks out, and then you would remeasure periodically, and to be periodically just means when they come in for their regular labs. And here we've shown you a bit of a dose adjustment pathway. Basically, if it's less than 4.8, you could increase the dose. If it's 4.8 to 5.5, you could maintain the dose. In terms of hyperkalemia, so I'm a nephrologist. I don't worry too much about hyperkalemia, certainly mild hyperkalemia. I would say at least up to about 5.5, 5.6. We don't really do too much. We just have a conversation about diet. It's only when there's a 6 handle on it that we get excited, and we will ask the patient to repeat it. And we'll go through the medications that may hold medications. I think the big thing here to note is that if you hold medications, the patient makes some changes, and a few months later, or a few weeks later, I should say, the potassium is in the normal range, do not be afraid to restart the medication, because the medications we're talking about may be cardioprotective, kidney protective, may save a life, whereas the hyperkalemia is more of like a lab-related nuisance, unless it's severe or recurrent. So hyperkalemia is common in finerenone patients. Shows up at about 15 to 20% of patients. Hypotension declining in eGFR, hyponatremia is doesn't show up that often. Doesn't show up in the trials. Doesn't show up really in clinical practice. Hyperkalemia truly is less if there's concomitant SGLT2 inhibitor therapy. So that's another potential benefit. Blood pressure change, really no change. 3 in systolic, 1 in diastolic after a month. Stable thereafter. Little bit of a dip in eGFR maybe at the beginning, just like RAS inhibitors, just like SGLT2 inhibitor. Really, the only thing I would want to leave you with is check the potassium 4 weeks out. And if you're going to check a potassium, you're going to check a chemistry panel. So check a creatinine and a potassium 4 weeks out, and follow it from there. Some of the patients may have an increase, in which case you may hold, you may continue. For most patients, this may not be an issue. So with that, I could end my rapid fire tour and hand over to Alex.
Thanks, Nav. I really thought that was an excellent presentation. I think that, this group in particular, not so much experience just yet with finerenone. And obviously now we get to the fun part of the program, where we'll, of course, rely on all of our attendees to answer questions. And we also open it up for discussion. So if there's actually a cost question that has come up, since we have a couple members of the Bayer team, if someone could answer in the chat regarding the cost. And it's a good point that Ronnie's making, as that'll be one of the practical considerations that we will also have to decide as we kind of build that patient profile for the queries. So why don't we just jump right into it? A lot of us might be familiar with kidney failure risk equations, some of us less familiar. I think more of us certainly amenable to the KDIGO heat map. So we'll go ahead and launch the first poll. Actually, Nikki, I'll ask you to launch the poll if that's okay. And the idea here is for you to answer as you would typically do so in your clinical practice, whether your approach, if you plan on selecting an MRA, would be based on eGFR and KDIGO, maybe based on the kidney failure risk equation, both of them, another demographics of the patient, maybe age, your gut feeling, you're still unsure about this medication or how you would select it. Go ahead. Obviously, we'll give everybody a chance to answer, as I'm sure everybody's mouths are full from whatever's left of dessert after their dinner. Yeah, that's a good question, Jill. It might be. I think they'll have to build something in order to do that. So that won't be the manner in which we do it, but we'll hold that question right now and we'll come back to it shortly. Okay, great. I think we got most of the audience answering. We can end the poll and obviously show everybody the results. It seems like we're still sort of in the domain of the KDIGO heat map and EGFR and urine ACR. Well, maybe about a quarter who would use both this as well as the KDIGO CKD dashboard for TELUS. Excellent. So that's good to know, as Dr. Tangri is telling us in the chat. And some using demographics. Fortunately, nobody's using their gut feeling, as of course, Dr. Tangri has already shared with us that our gut feeling tends to be, well, way off, to say the least. Let's jump right into the second poll. Just some background information, actually, before we get to the second poll, was that the risk stratification based on the kidney failure risk equation, obviously think of it as either a percentage that would be presented to you in the form of a prompt, in the form of something that might be built into TELUS, or you might stratify it the way that we were just presented into a low risk category of 0 to 5%, intermediate risk, and of course, high risk, where I think many of us might consider a referral to a nephrologist, or certainly an escalation in therapy. So something to think about, as there'll be a few different ways that we can present this to you, if this is, of course, the direction that we plan on going with for the prompts. So what about the burning question? I would consider starting finerenone by either prescribing it, making recommendations, referring to a nephrologist, or we're still unsure. And once again, we'll wait for everybody to answer. While people are answering, why don't I just bring back Nav to pick your brain on this one? Are you getting referrals just yet for the consideration of this medicine, or still too early to say?
Yeah, I think it's probably too early. So I'm in the same boat as most of your colleagues, that I prescribe it because I find that making a recommendation is just, you're leaving too many doors to, too many variables in the equation. And but I am trying to put it in my letters more and more, saying that the concept of goal-directed therapy and therapies that slow progression, putting it in my letters so that hopefully the family physician can prescribe it on their own for patients who don't yet need a referral. But I think everyone who wants to prescribe it, just prescribe it. Like, just a recommendation. I'm so happy to see that there's 0 out of 26 there, because that just doesn't work.
Excellent. So we'll share the results of the poll, as I think most are in agreement with your assessment, which is, about 4 out of 5 would prescribe it themselves. A quarter still comfortable with referring to a nephrologist. Practice patterns, certainly from the last decade or so, would tell us that maybe not amongst endocrinologists, but amongst family physicians, it's that usual pathway, usually by referral, and then as you see the letters come back and you become more comfortable with this patient selection and the prescription, that you yourself then prescribe it. But they don't actually have that much market data about specialists. And so I'll pause there just before we get to any of the additional polls, just to present some of the LMC research, which we're very fortunate to participate. This was also Bayer-funded, investigator-initiated research for the LMC data science team. And the CREDO study, which involved a survey of many of you who are in attendance, actually revealed to us what our profile of type 2 diabetes in patients and CKD actually looks like. So we have about 53.6% of patients in the stage 1 or 2 category. Our mean eGFR across roughly 60,000 patients with diabetes is 67. And you can see the breakdown based on the KDIGO stages. Amongst microalbuminuria, we have about 62% of our patients that have microalbuminuria. There's a median of 5.1, and about 20% of our patients also have macroalbuminuria. So, of course, these are, some of the patients that Ron and Dr. Tangri have, of course, presented to us. This was another LMC publication that the LMC data science team led, along with collaborations from Dr. Lin and Dr. Steele, who's a nephrologist in the GTA. And what we demonstrated with this survey, which was a survey of both endos, nephs, family physicians, and patients from across the country, was really to reveal that disconnect that you see between patients, providers, and the different specialties. So for that stage 3B A2, or your patient with an eGFR in about the mid-30s, low 40s, and who has macroalbuminuria, 2/3 of nephrologists agreed they should be seeing that patient. That same patient presented to primary care and endos. Less than half of the primary care physicians and only 40% of the endos felt that that patient should be referred to a nephrologist. So as alluded to certainly by Dr. Tangri, that the boat, often missed anyways in this patient when it comes to reducing long-term risk. We're still not even referring some of these patients to nephrologists, even in a national survey of providers. And amongst UACR, well, most primary care physicians, or just over half, refer if the UACR goes over 20. Amongst endos, more than half needed to be over 60 before we refer to a nephrologist. So again, just demonstrating some of the data that we were able to publish in the last year. We'll obviously present just a few quick polls now, really just to gather and generate discussion. And then we'll, of course, have an opportunity to answer some of the questions that were in the chat. And we'll obviously open it up on the last slide to gather any feedback from anybody who has an idea that we might be able to use for the query, be it a kidney failure risk equation, KDIGO heat map classification, or something else if you feel there's a burning issue here that's still lingering.
Just while I just really interesting data that you just shared. So interestingly, in the UK, they did a sort of cost effectiveness analysis nationally on referral guidelines, and they would side with the endocrinologist that probably for a UACR 60 is the right cutoff, actually, from a if you assume that there is not an abundance of nephrologists. So there is a system like ours, like obviously in any health system, there's an abundance of any resource, then it doesn't matter. You don't need an economic consideration. But 60 was the right ACR cutoff. Now for 3BA2, that's where actually the risk equations can be really helpful, because in 3BA2, you could be 1% risk of dialysis in the next 5 years, or you could be 30% risk. So in the UK, they picked 5% over 5 years as the cutoff, which is what the kidney-wise, I think the ORN toolkit also has. So we've been trying to think about revamping the ORN toolkit and also just having the risk equation built into labs so that this can just come out sooner than later for everyone, and might remove some of the uncertainty around 3BA2.
Wonderful. And at least amongst our group, we seem to be comfortable with starting the medicine as long as the potassium is less than 5. We'll make sure we incorporate that into the query so that it doesn't come up. And 2 more polls before we'll open it up for questions. And then, of course, thank everybody, including our speakers. So amongst the question of cost, which I'm not sure if we actually got an answer for just yet. If we don't get an answer, we'll certainly.
I think it was in the chat.
Sorry,
334 per day.
For what?
$3.34 per day.
Oh, yeah, we did get it. Apologize. Yeah, sorry, yeah. I do see it. So $3.34 per day. If you want to do the math, it sounds like it's about $100 per month.
Like all new drugs.
Exactly.
Okay, great. I think we have, it's still actually coming in with regards to this question. And as of now, as you know, certainly the context for this question, no public coverage, I think, on any formulary just yet for finerenone. Some good uptick with the private coverage from what I hear from my rep and my MSL. Thus far, the handful of patients that I have, I think I'm in the C category of 2 patients. Yeah, it hasn't been an issue like you'd expect with some of the new drugs and the forms and the bounce back, at least for my N of 2. Okay, good, Nikki. We'll show this result as well. This, I don't think any surprise, at least for a new medicine that you're considering, tend to want to facilitate the prompts. Yeah, I don't think, you could qualify the cost in years of life that would prevent dialysis, although some would put a very high price tag on that. But, at least for our purposes, I think the idea is that we want to facilitate the prescriptions and public coverage, as we hear from Sophie, who leads the Bayer team. I think you might mean 2024, unless you're going to surprise us with public coverage in the next 9 days, Sophie, in which case that would be incredible news. Yes, okay, 2024, as we thought. Good, let's advance to the last poll. Here's another question, obviously more of a practical consideration than a who you feel would actually benefit from this therapy. Consider this more of a how comfortable are you prescribing this relatively new agent based on KDIGO, based on risk stratification, based on the fact that they have private coverage. Who would you not feel comfortable prescribing this in anymore? Is there any age limit? Are they over 85? Are they over 70, 65? This is more of a, gut feeling kind of answer for you. Seem to be settling. Yeah, so we have the majority who've answered. So about a third, no age limit. Almost half, around 80. We'll have this opportunity to answer this as well in the evaluation so that we collect everybody's opinion, both those who are answering live, as well as some people who've opted to watch the recording of tonight's presentation as well. And that obviously takes us to the conclusion of the polling questions. There are some additional questions that you'll see are worked into the evaluation. So we'll collect all of this data and try to come back with everybody with a profile or profiles of patients that we feel are most suitable. Let's go ahead and close the poll. So this was put together in advance. Obviously, this might have changed a little bit based on our discussions. The idea of a query, obviously, is that there are certain parameters we can query in our EMR. And Jill has asked the million-dollar question with regards to our TELUS migration to May. The idea is whatever EMR we're using, we plan on essentially mining the back end of the EMR. And then based on the demographics that we collect for these eligible patients, if we're going to apply a kidney risk equation, it'll probably be in something like Excel rather than directly in the TELUS EMR. Although that is a super cool idea, and we'll bother Nav again in a couple of months so that we can be the first to utilize it. But the idea is whether it's Accuro or whether it's TELUS, it'll be a similar collection of data, and then we'll do it afterwards. Throw in FIB4 too. We'll collect all of your feedback, Jill, but at least for this one, we'll try to stick with kidney rather than liver disease. But I hear you. Okay, good. And now, obviously, I think we came to a couple of questions. I'll ask the first one that we got to Nav. And of course, if you disagree with any of these query criterias, there's a couple of different ways that if you'll, be so bold as to answer in the chat, that when and if you opt for an EMR prompt, it could look like one of these prompts where we give you the KDIGO score and the percentage of kidney failure risk equation over 5 years. We could stratify that into low, medium, and high so that you don't have to remember what the percentage category fits into. Or we could just give you the kidney risk failure equation of either medium or high, considering that, you probably wouldn't be considering too much extra therapy in somebody who's low risk. But this, obviously, we welcome any comments in the chat, any comments in the evaluation as to how you might like to see this if it's in an EMR prompt. And obviously, we'll try to make it as practical and as amenable to your workflow when we obviously build this in. Same question, obviously, as well, if you opt for just lists of all of your applicable patients, which we'll probably distribute monthly, that'll be a similar type of profile. And at least for now, since we're basing it on some of the trial data, product monograph, ACR being still the question mark here with regards to whether we would use just ACR or whether we want to work that into the kidney failure risk equation. And even maybe you think of this in your type 1 patients, very much off-label. And there is a trial that I think is going to be starting soon at some LMC sites. But maybe this data is meaningful enough to you that really diabetes and hyperfiltration doesn't really make a difference to you one way or another. Some argue, even for SGLT2 inhibitors, although that too is even off-label. And I think that the way we had conceived it, or at least the way that I had thought about it, was that this won't be in the prompt, but the idea is that this is a tool to help you reassess the 3 pillars of kidney medication, or perhaps if it's a medium or high risk patient, maybe a referral to a nephrologist. And if you feel like some of our cardiovascular programs from a couple of years ago, that the list of referrers at each site, since many of us work with nephrologists, some others may not know the nephrologists in the areas, we're happy to make that available again in the EMR. We'll approach a few nephrologists and try to facilitate referrals, for these specific reasons. If, again, you feel that's worth it, because about 4 out of 5 did say that they would just prescribe it themselves. So I'm not seeing any outcry or really disagreement in the chat. That obviously will allow me to just cover the next steps, and then we'll come to the questions, which is that we're reviewing the program. There will be an evaluation, which I'll share at the end, which you can complete now, and it'll be emailed tomorrow. And then over the next 6 months, we can expect, obviously, to be reminded about these type of patients. And the way that you're reminded is up to you, completely discretionary, whether you want that one-time EMR prompt that our LMC pharmacy is nice enough to insert, list of all identified patients, or whether the education was sufficient. And so I'll open it up to questions. I think, Nikki, if you'll go into the security and allow people to unmute themselves, so you can feel free to ask your question live. I'm glad that Ron came back, because I was just going to invite you back, but we got a question early on, which I'll flip to you, Nav. But if you run into trouble with hyperkalemia, what do? Are you reducing the ACE, maintaining finerenone? Are you dropping finerenone either entirely or the dose? Any kind of practical tips there?
So I think if it's like immediately in response to the finerenone, so the first thing what's happening is we're not initiating about 4.8 at this early stage, because I'm still in the single digits of patients on. So if I'm not initiating below 4.8, I haven't seen anybody above 5.5, so I haven't had to stop yet. But what would I do? I think if the patient, I would decrease the dose of ACE or finerenone, although most of my patients are already on 10. And I usually try some low-hanging fruit diet changes, particularly some very big hitters like tomatoes, potatoes, and oranges. And in some, obviously in South Asian culture, so lentils and things like that. If somebody says that, if I don't find those, then I think that I have to do something with the medication. Sometimes it's just like a very obvious culprit. But usually I try to tell them that the therapy is important, try to get them to make some changes with their diet, try to keep them on therapy rather than I'll lower the dose, but try not to discontinue it altogether.
For NAB, and I learned this from my nephrology colleagues over the years, the patients who run into trouble with hyperkalemia are usually the patients with the very low GFRs, not the patients that we see with GFR 70, 80.
Yeah.
And I think we should start measuring the CO2 or the bicarb in these patients, because as your GFR gets quite low, they may benefit from some sodium bicarb, which helps the potassium as well. And I know nephrologists do this all the time, but I don't think many of my endocrinology colleagues are doing that.
It's very interesting. So I actually led a multi-center global study on acidosis, and LMCs were clinics for one of the sites. And I was surprised that your routine panel doesn't include bicarb. Yeah. And we actually, you guys are such a spectacular clinical trial recruitment site, except for this trial. And because we could never find the right patients because they didn't include bicarb. Yes, I think patients with low GFR, so if the GFR is less than 60, you should measure a bicarb as part of their panel, just as a part of their panel.
And I didn't mention before, but we'll wait to see the evaluation results for the kidney failure risk equation and whether you'd like to see that tool as part of the prompt. But I think there's two calculators, Nav, one that's the parameters that you laid out plus age, and then one that also uses bicarb and phosphorus and some extended spectrum electrolytes.
Yeah.
We probably,
and I think, yeah,
go ahead.
Go ahead.
I was just going to say that while it is considered to be more accurate if you're doing your own research on the kidney failure risk equation, since we don't often measure these, it might be a little bit more difficult to query it. But if we see some high-risk patients and we want to expand the query because we are able to do it, we can explore that. But I think we'll be using the simpler equation just for transparency.
Yeah, I would agree with that approach as well. And I would say that it would be great if, and I don't know if this is possible because we're just kind of brainstorming at this stage, it'd be good to have a look at the data across the entire practice and see what percentage of patients fall across what levels of risk. Because I think we have some flexibility here on setting the prompts at a stage, right? I think it's important to not give too much prompt fatigue. You know, if everybody's high risk, being high risk loses its meaning. Yeah. So I think as a first step, we should look to see what is the risk profile of I know very well what the risk profile is of a nephrology practice, but I don't know of an endo practice. So it'd be good to take a look at that as a first step.
And that is a great point as well, because if we were prompting you over the next 6 months for 500 patients, I don't think anybody's going to come out to this exercise anymore going forward. Yeah, historically, it's a few dozen patients, max of 50 that we've usually done sort of per list. It might vary in this case, since it's obviously type 2 diabetes and CKD. But yeah, the message about prompt fatigue certainly was well received. We got another question in the chat. I'll open it up to both of you if either of you know, but what percentage of patients screen failed in like the finerenone trials due to hyperkalemia?
It's a good question. So I think like the Fidelio, like they screened like roughly 14,000 people and ended up randomizing a little less than 6,000. So then, about 50% of people screen failed, but the large majority of them are because they didn't meet the ACR or GFR criteria. I'm not sure of the percent that screen failed because of hyperkalemia, but remember they use 4.8 as the cut point, not 5. So if your potassium is like 4.9, you would not get in to those studies, even though in clinical practice we would cautiously prescribe it, because even the product monograph says 5 is the cut point.
Yeah, I don't see it broken down. I'm looking at the paper and I don't see it broken down how many screen failed for what reason exactly. So
okay, excellent. And the publication, if anybody is having difficulty accessing it, we're obviously happy to share that. You can email myself or Nikki. We'll happily make that available to you. Or, of course, I'm sure Bayer on the MSL end will also be more than happy to do so. I'm not seeing any additional questions in the chat. There'll obviously be some offline discussion as we sort of narrow in. I'll pause for a moment there if anybody has any final questions. And we'll also ask, as part of the participation in this program, that you complete the following evaluation. There'll be the initial evaluation here, and then a sort of a briefer feedback evaluation that we distribute in October or November of 2023. The way to access the evaluation, you can either type it in. There's the link that you can't click on the page, but that's available in the chat. And you can also use your phone to scan the QR code. Nikki will also email this to everybody probably in a couple of days after those who registered but weren't able to be here tonight and will watch the recording of the program. Will also have an opportunity to fill out the evaluation. So certainly with no other questions in the chat, I think we'll end tonight's program. Another humongous thanks to Dr. Goldenberg and Dr. Tangri for really excellent presentations. Some amazing work you're doing, Nav, with risk stratification, and truly impressive working with you and impressive hearing you present tonight. Nobody believed you were retiring, Ron. I still don't believe you're actually retiring, so I'll probably call on you again very, very shortly. But great presentation.
Retiring from clinical practice.
I know. But everybody just shortens it to retiring. Whereas, I feel like I'm seeing you more now than I did when you were in practice. But we'll continue to do so. Thanks everybody for joining. Thank you to Bayer and thank you to Nikki for obviously facilitating. The slide will stay on the screen. But obviously for all those who need to depart, we thank you again for joining us and have a great night.
Thank you for including me. Thanks, everyone. Bye.